Welcome to Patient in the Room, our first episode from Australia. Thank you for joining us today. This is Dr. Ruth Mitchell, a fellowship-trained neurosurgeon specialising in paediatric neurosurgery, epilepsy surgery, and brain tumour management. Also, it would be remiss of me not to mention that she is a 2017 Nobel Peace Prize winner. First of all, Dr. Mitchell, thank you for being here.
It's wonderful to be here. Thank you for having me, Benj.
Very exciting times. Obviously, today it's all about the work that you do for, the families that you work with, the children you work with, and I guess the teams you also work alongside as well. I always like to start understanding you. So could you just explain to us a little bit about what a neurosurgeon really is?
Yeah. Look, I think it's the best job in the world. I get to look after people who are having problems with their brain or their spine, and specifically diseases that need surgical management. But not everyone I see does need an operation.
Okay.
So, but we do look after a range of patients, and I'm very fortunate that I do pediatric and adult neurosurgery. So I look after people who are, born yesterday and people in their 80s and everyone in between.
So how often are you seeing newborns and infants?
It seems like they all come in little groups. So won't be any for months, and then you'll have 3 or 4 babies in the neonatal intensive care unit that you're visiting every day. One of the things that can happen to babies if they're born prematurely, if they come too early, is they can have a bit of a bleed into the fluid spaces in their brain, which means that then they get too much pressure inside their head with the fluid. And sometimes we have to operate on them when they're, not even at term. So the smallest baby I've ever operated on weighed 800 grams.
My gosh.
Yeah.
Wow.
Not enough baby.
Yeah, that's like, it's like I order more chicken from the supermarket.
Exactly. It's less than your milk weighs.
Yeah, that's wild. When you're dealing with an infant that young, because obviously they're going through this extreme developmental period for their body physiologically, are the risks different in terms of the recovery, or does it change?
So most of the time working with kids, we feel like kids are like super resilient and like they bounce back from all sorts of things. Newborn babies are not in that category. They're very vulnerable. And in fact, occasionally a child that small is so unstable that we wouldn't even take them to the operating theatre to operate. Occasionally we might even organized to do the operation in the neonatal intensive care unit.
Wow.
Just so that even just moving them from one place to another can be quite disruptive.
Okay.
So we're just trying to keep things as calm and as controlled as possible for their very fragile physiology.
Yeah. Well, that makes sense. I guess taking the route of the safest route to make sure that there's the least amount of risk. Okay, good to know. Bringing back to sort of, I guess, neurosurgery as a whole, someone's referred to you or referred to a neurosurgeon, does that automatically mean that they're going in for surgery?
No. So not all the patients we see actually do need an operation. In fact, quite often people come in worried that something that's been found on a scan will need to be operated on. And we have a look at it together and we decide either that they don't need an operation or that they don't need an operation yet. So, for example, we might find a cyst in their brain, and it might look big and dramatic, but it might be something very benign. It might be a normal variant on the anatomy. There's something called arachnoid cysts, which are very common, and people see them and get very worried. And we almost never operate on those. And so other times we might see something and think, that's a very small lesion. It's probably benign. If we do an MRI in 3 months and it hasn't changed, then we might not need to do an operation. We might just be able to watch it.
Yeah.
So it's not always the case that if you have to come and see me that we're definitely signing you up for a procedure.
Okay. I think that's going to set a lot of people's minds at rest. And you mentioned we talk and we have a conversation and we look at things. It seems like it's quite a collaborative approach.
I think as much as possible, I want patients to feel like they're in the driver's seat. They feel loss of control when they're having to come and see a specialist, and they feel like they don't know what's going to happen. And I want to make sure people feel that they have, all the information that they possibly could have to make decisions about their own healthcare and their own bodies.
Yeah, it's a really important thing. And I guess that builds confidence in the decisions that are being made, and there's a bit more trust involved. You mentioned that there's lesions that you look at that might be benign. So is that to say that not all tumours or brain tumours are cancerous?
Yeah, that's right. So actually, there's quite a few brain tumours that aren't cancerous. Now, just because it doesn't look cancerous on the scan doesn't mean it definitely doesn't need to come out. So everybody is so different and every situation is individual. We have to look carefully at the whole picture. And people wonder, why could you have a brain tumor that doesn't look like cancer but still needs to come out? And the answer to that is really a bit like real estate. It's all about location, location, location. So if you've got a lump in a bad spot, then if possible, it's good to get that out. And especially if it's something that's decided to grow. But I think that it's really important that patients know that they can have these conversations really frankly with their neurosurgeon and learn what's unique about them and their scan and their circumstances.
Yeah. Okay. That's good to know. And I guess just on that location comment, is there a good area and a bad area?
So an example of an area where we could possibly just watch a benign looking, say, for example, there's a tumor called a meningioma, and most of those are benign. If you had one that was small and hanging out far frontal, particularly if it was on the right side and you're a right-handed person, so I know that you're left hemisphere dominant for speech and language, I would say, hey, if it's not bothering you to think about that, having that in there, that might be something that we could watch as opposed to signing you up for an operation straight away. But even then, patient preference would matter. Mm-hmm. So sometimes people can't stand the idea of having something in their head. Yeah. And that can help us, that can nudge us towards offering an operation.
Yeah. Okay. That's interesting to hear that, just even if it isn't going to do anything negative, but the patient says, I actually don't want that there, then that gives you the power to be like, okay, we can perform the surgery.
It's reasonable to do this. It's also reasonable to do this. So bringing the patient, there's times when you really can bring it into what's the patient preference.
Yeah.
There are other times where I see something on the scan and I'm like, this is a bad news conversation. I think that needs to come out. This is my recommendation.
Yeah.
But there are always other options like doing nothing, doing just a biopsy as opposed to trying to get a whole tumor out. And it's important as well, I think, for patients to know that they can always get a second opinion.
Yeah.
So if you're not sure that you like the plan you've been handed or you're not clear that you've understood it well enough, then I think I really encourage patients, if they're having any of those feelings, to feel very free to get a second opinion as well.
Yeah, this is a very important part of your body. It's the brain at the end of the day. You can't live without it. So I think that's
Exactly.
a really good point you're making. Everyone should be able to feel confident in what's going to be happening to them and speaking to the right people to build that confidence and make sure that the right decision is being made. It's really important. I guess that leads on to the next part is, when in a patient's journey would they come and see you?
So sometimes I see someone because their GP has investigated them for, like, say, a headache or back pain or leg pain, and they've done some imaging and they found a thing. And so then they're like, I don't know what this thing is, but I know someone who can talk you through this. So often I'll have a referral that way. Sometimes we have a finding on a scan which isn't causing any trouble, but we just found it because, for example, someone was out on the weekend and they fell off their horse or their bicycle and they hit their head. And so now they had a scan and there's a thing on the scan. So those kind of things are called incidental findings, where it's like, surprise, but not in a good way. And so then often I find myself having conversations with patients who have just been completely startled by finding they have either an aneurysm or a brain tumor or something else new that they didn't know about.
It's really interesting because I guess those patients, they're not expecting any of this. Do you find that they're more difficult to have because you're dealing with an element of shock and surprise?
Yeah, and so the even more extreme version of that is when I'm meeting someone in the emergency department, or one of my registrars, one of the members of my team has met them in the emergency department because they've come in because they've had an accident or they've had a seizure or something, and this is how we found out that they have a neurosurgical problem. And so, the elements of surprise come in lots of different ways. I understand that the day you meet me might be one of the most shocking days of your life. And for some of my patients, it's the worst day of their life and of their family's life because they're finding out that there's something on the scan that's going to limit their life, that's going to change their life. And certainly the next few weeks will certainly be very, very different than they were going to be. And so dealing with people's uncertainty and frustration and pain and, there's all the parts of like the grief cycle come out. So sometimes people want to negotiate. They want to go through a period of denial. It's not uncommon for people to be angry when they find out that there's something wrong. And so being able to sit with that and buffer that a bit is also part of my job.
Yeah. On that note of all the different emotions that they're feeling, if you were to give a piece of advice to patients listening today, what's one thing that you want them to know if they were unfortunate enough to have this conversation with yourself or one of your colleagues? What's a piece of advice for them to, I guess, help them in that moment?
So I think I really would want all of my patients to know that there's no question that we don't want to hear. So whatever's worrying you the most, like tell me, ask me, what's the thing that we haven't talked about that you're worried about? And often people are worried about their future, or maybe the future for their child if I'm talking to them about their child, or maybe they're worried about their kids because they think, hang on, am I going to be here to see them grow up? And so being able to have those conversations and make enough space for people to really tell me what they're worried about. If you don't feel like you're being heard by your doctor and you've asked the questions that you want to ask and you don't think you're getting answers, I think definitely finding someone who will answer those questions for you is really important. I really encourage people to do that.
Yeah, I think that's a really smart step to make sure that you're with the right person for you. If you were a patient, you're in that position and you haven't been able to get that connection with that doctor. This isn't a pitch for Doctify, by the way, but what would you recommend them doing? Like, what's the next best step for them? Do they speak to that surgeon and be like, look, is there someone that you can recommend me to for a second opinion? Or do you speak to another part of the medical team?
So I think that most of my colleagues, I think, would be very happy to make a suggestion about another colleague who they know works in the space in the right way. Most of us as neurosurgeons have pretty broad scopes of practice, but we often have special interests or fellowship training and extra training, as well as a body of experience with specific problems. So if you came to me and if you came to me and it looked like you needed actually a spinal fusion, that's not something I spend a lot of time doing. It's not a big part of my practice. So I would have a list of my colleagues who I'd be super happy to recommend to you. And once you've met someone, you can sometimes even do a bit of like personality matching where you're like, I think you'll get on with this one. And I like that. I like being able to do that.
Yeah.
And so I think that in the first instance, if you think you'd like a different opinion, it's always reasonable to ask the person that you've already met with. And I would hope that wouldn't be met with hostility by any of my colleagues. But in the case that it does, there's always the option to go back to your GP or whoever referred you to the surgeon to say, hey, can you make another referral for me?
Yeah. I like hearing that, especially the part where you said, the personality matching. You've spoken a lot about the communication and the support and, the collaboration that comes together through this experience. So having that ability to connect with that doctor and for the doctor to connect with the patient is a really important thing because it's a scary time. And it sounds like you, from what you're describing, are very much there to hold their hand and make sure they feel safe and comfortable. And everyone's got their own approach and everyone is a different personality. So that's a really important thing. You also mentioned specialties and areas of expertise. Obviously for you, paediatric neurosurgery is a big part of what you do. If I'm a parent hearing that my child needs to go in for neurosurgery, the first thing I want to understand is risk. So how do you talk about risks in pediatric brain surgery to the parents?
So I think it's important to put things into like a big picture about what are the risks and the benefits of doing a procedure, but also the risks and the benefits of not doing it. And so when I go through a consult with a patient or patient's parents, I normally start with what are the indications? So what are the goals of the operation and what are the upsides of doing it? We're going to get a diagnosis. We're hopefully going to get the whole thing out, that sort of thing. And once we've So it's almost like this two-step process. The first is I try and talk you into the operation. Here are the good things about the operation. This is why it's better than doing nothing or, an alternative procedure. And then once I've convinced you that this is worth pursuing, now I'm going to try and talk you out of it, which is where I bring out all the risks and say, there are some things that can go wrong. We aim very much to bring our risks for this kind of procedure down to zero, but we never get to zero with the risks that exist. And then I try and group things for people so they can kind of get their head around them. And I know it's a really overwhelming conversation, so I'd like to sort of slow down and check if they're kind of tracking it. Sometimes people get very overwhelmed when you talk about risk and they get anxious. And I've had patients get, quite emotional. And so then just stop and let everyone catch their breath and find out what is it that they're particularly worried about. Mm-hmm. And that's often when you find out that like someone in the family's had a really bad surgical outcome, for example, or something like that's happened, which is informing their experience with what you're talking about. And if you don't get the elephant in the room addressed, then you can't get back to talking about this operation for you or for your child in this instance. And it's not going to be the same as what happened to your aunt. It's not going to be the same as what happened to someone from the kid's school. It's going to be different, and here are the specific risks here.
Yeah.
And so letting people know what are the common expected outcomes as well. So, your kid's definitely going to be a bit grumpy after the operation. There'll be a combination of sleepy and grumpy, and they might be a little bit off their food. Letting them know things like when we do operations around the front of the head, they might have quite a swollen forehead. They might even have swollen eyes. Their eyes could swell shut. Let them know that. Let them know it won't last forever. So give them the sense of what to expect. What's actually the expected postoperative experience? How long are you going to be in hospital? And then once all that kind of what's definitely going to happen is in place, then what could also happen? It could happen that you have a stroke. It could happen that there's significant bleeding. Then you find out if they're willing to have a blood transfusion, if that was indicated. Really important to have that conversation before you need a blood transfusion, because if someone has religious reasons why they would not want one, it changes how we plan for an operation. Yeah. And we really need to know that early. So finding out about the patient as you discuss risks is really important.
Yeah, sounds like it's also an opportunity for patients to really open up to you and share their thoughts and their feelings around things. Do you find that there's ever a difficult barrier to break through with parents, or do they normally, because it is their child, they're pretty relaxed and saying, look, here is everything. I don't want to hold back any knowledge.
Every family's different. And often the probably the most the families I feel for the most are the ones where there's already been another child who's had ill health and has been in and out of hospital. Often families and kids pick up kind of hospital-related trauma and healthcare-related trauma from those experiences. If you've got kids who have complex syndromes and have spent a lot of time in hospital already, you're dealing with all that backdrop. So you really have to be respectful of that and try and pay attention to what are they responding to? Are they responding to something that I just said, or is it because it reminded them of something that happened to this patient's brother or this patient when they were younger? And I think being able to get that kind of information out is really helpful. Because when we're having a conversation about an operation for your child, I'm building a bridge for the whole encounter. So we really need to have a strong connection that we're building now. So no matter what happens, we're going to be in it together. Yeah. And I think that's the kind of the vision I have is like we're building a connection, which is unlike any other connection, really, the relationship between doctors and patients. And lots of people want to commodify that. They want to use sort of marketplace language around it. But I think the doctor-patient relationship is really special. And we have to invest in it, and we have to fight to preserve it.
Yeah. And I think that fight comes from both sides. Patients, they want to trust, but you mentioned, past experiences. So working through those fears, being open with the doctor and making sure that their fears are being heard and met and understood so that they can do the best thing for their child. Because at the end of the day, it's not about them, it's about their child, and you're there to give them every piece of advice to guide them in the right direction that they feel is for their kids.
And sometimes it's not just advice. Sometimes it's resources. Occasionally there'll be a patient, a parent who's just found out their kid has like a big diagnosis, like a syndrome, where there'll be multiple different teams involved in looking after them throughout their life. And fortunately, for some of those conditions, which aren't very common, there are support groups. And so sometimes we can also be part of connecting them. And that can be very empowering and very reassuring. So people understand that their experience isn't unique, and that, well, it's unique, but they're not alone. And that there are communities of people who are, in very much the same boat.
Yeah, I think that's a really awesome thing to hear, that you guys give more than just the medical side. You're understanding the community that's required to deal with things. The old saying is it takes a village to raise a child.
Yeah.
And we're always going to be children, someone's child. So we're always going to need our community to help raise us and keep us moving forward as well.
Absolutely. And the villages that are needed to raise a child with significant disability or one of these more complex diagnoses is really such an important part of their well-being. So when I see myself as a surgeon, I'm just one part of that big tapestry, one part of that village. People often think the surgeries are like the most important thing that happens, but that's not the case. There's a place that has in the overall care of a child that, has to be understood.
Yeah. Just moving on to, I guess, the surgery aspect of things.
Yeah.
One very practical question that parents ask for their kids, and you kind of touched on it before about setting expectations, but how much pain typically is there for a child after brain surgery, and how do you manage that?
So it depends very much what the operation has been. If we do an operation where we are, doing a craniotomy, so we're opening up the head, we're taking out a window of bone for the duration of the operation, opening up the lining of the brain, and then doing something inside, whether it's taking out a brain tumor or another or a cyst or something like that, or taking out a focus that might be causing epilepsy, then I find that there's a certain amount of pain postoperatively, but that's pretty well managed with our current kind of pain protocols. And one of the things I want parents to know is that nursing staff who work in pediatric settings are really good at picking up when kids are in pain. Even if they're really little and they're not really verbal yet, they don't have a big vocab to tell us that they're sore. There's behaviors that kids have when they're in pain. Their heart rates go up. Sometimes the blood pressure goes up. And so the trained nurses that will be looking after your child after the operation, they're really good at picking up on that, and they can help with that. Sometimes, for example, if I do operations for a condition called Chiari malformation, which is an operation where we're making a bit more space at the back of the brain, at the back of the head, where the head meets the neck. And with that operation, we have to dissect through quite a lot of neck muscle. So that's really sore afterwards. So then we tailor our post-operative pain relief to that and try to make sure that we stay on top of that as best as possible. So each operation has a bit of a different strategy for managing post-operative pain, and part of that starts before we even do the operation. So thinking about where to put the local anesthetic, how much, and also speaking to my anaesthetist about what medication to give during and after the operation.
Yeah, sounds like the reassurance that patients might need to hear that each individual is treated as an individual, and the staff know how to read signals that we might all be missing, even as parents.
Exactly.
And I think that's the confidence that people need to hear, so that they know that my kid's in good hands. There's a lot of people looking at them to make sure that they're comfortable in that recovery.
And I think the other thing to mention is it's very much managing pain postoperatively is a very multidisciplinary thing. So we actually have a pain service at Sydney Children's Hospital where I do my pediatric cases. And so we can ask them to specifically drop by and see our patients whilst they're recovering to make sure we're not missing anything and just make sure that's really been optimized.
Amazing.
So it's a team sport.
It really is. Really is. Moving into that, I guess, recovery aspect, is there an average period for recovery from brain surgery? Is it days, weeks, months?
So there's different stages of recovery. Kids recover fantastically well in general. And often will be going home something like day 3, 4, or 5 after an operation. Sometimes it's longer. It depends what the case was. But for elective cases, that's often the expectation. For other cases, they might be in a bit longer. Things that happen because someone's had an accident or it's been an emergency case. Often there's more things to be sorted out, so they often are in hospital much longer. And so the hospital phase is obviously the acute phase of recovery.
Yeah.
And if you're a grown-up who's had brain surgery, who lives by themselves, then we have to make sure that you can do everything for yourself before we let you go home. But if you're 3, I mean, you're not doing your own groceries and laundry, and you're not preparing your own food, and you're getting help with toileting and bathing. So the threshold for letting you go home safely is very different. And so we can often get kids home earlier in the journey than we would a grown adult, partly because, past a certain threshold, kids get better faster at home, with their familiar environment, their routines, and sometimes in hospital there'll just be one of their parents there. They might have 2 parents at home. They might have siblings, pets, things that make, things and people that make them feel like themselves. So they often recover faster getting home. So I do try to get my pediatric patients home as soon as it's safe.
Yeah, that's good to hear. But obviously, it is a pediatric part of the hospital. Do they make changes to help create a nicer environment for the kids while they're there, like potentially dimming lights, having different sounds, reduced?
Oh my goodness, there's so much good stuff about kids' hospitals. Like, they're fabulous places, and there's things that the kids love about being in hospital. So it reframes the hospital experience. There's icy poles going around all the time. There's a fair bit of ice cream. There's something called the Starlight Lounge, where they can go and play games, and there's competitions, and they can win stuff. And often they come back up to the ward, once they're well enough to go down to the start. They've got face paint on. Their siblings have got face paint on. So there's play therapy as a big part of the hospital experience, and there's a lot of ways that joy is introduced into the setting. So I think, one of the sad things about COVID was a lot of those things had to kind of stop. And so in some places they haven't all been rebuilt yet. If you're an adult patient, you don't have quite the same volume of celebrities coming through the hospital to say hello as you do when you're in a pediatric setting. I remember one ward round as a registrar. I was working on Good Friday, actually at the Royal Children's Hospital in Melbourne, and I almost had to slide tackle the Easter Bunny, because the Easter Bunny had come round as part of the Good Friday appeal and was going to give my patient some chocolate. And my patient was fasting for theatre. They weren't meant to have anything to eat. They were just on sips of water. And this massive Easter Bunny was about to be in their face. And so I nearly was violent to the Cadbury crew. Bless them. They were very gracious about it when I explained that even just leaving it in the room was going to be mean for a kid who really cannot eat.
Yeah.
Cannot eat until after their operation. And I don't know when the operation is going to be.
Yeah.
So there's a lot of fun that happens in children's hospitals that is very different than what happens in adult hospitals.
Yeah. I guess to wrap up this pediatric point of the discussion, I know you mentioned that it's really important, and a big thing to come out of this would be for parents to ask every question and help deal with any sort of nervousness or any concerns. Is there any other thing that you want them to walk away from this conversation with?
I think letting people know that all their feelings are valid, whatever you might be feeling about this is legit. People shouldn't, beat up on themselves if they're feeling, sad or anxious. That's legitimate. It's all your feelings are legit. And I think the other thing I would say is, when you're the person who's in a support role for someone going through, a significant healthcare encounter, you have to look after yourself too.
Yeah.
So, you need treats, you need sleep, and many of the conditions that I manage, it's going to be a marathon, not a sprint. So you really want to be helping people to see ways they can look after themselves, even while they're wanting to look after their kid or their family member who's in hospital.
Yeah, I think that's incredible advice. Thanks for sharing that. Moving into epilepsy, this is one of your special areas as well. This is an area that feels a little less visible, but it's obviously very impactful. if I'm someone living with epilepsy, at what point does surgery become part of the conversation, if ever?
So not everyone with epilepsy gets discussed at a comprehensive epilepsy team level, but I think a lot more patients with epilepsy should be discussed, because often when we put the pieces together, we start to see that there might be a role for surgery. So many people with epilepsy, there won't be anything a surgeon can do. But there are times when someone's been living with epilepsy for a long time and finally they get to a neurologist who thinks, hey, maybe we should just have another look at this. And they're able to find a way in which surgery might be helpful. So to tell you a little bit more about the kind of comprehensive epilepsy teams that I get to work with. So there's two. There's one in the kids and one in the adults that I'm a part of, and I love that. The real workhorses are the epilepsy neurologists, who also sometimes get called epileptologists. And so this is someone who's done their training in either pediatric or adult neurology. And then on top of that, they've done extra fellowship training on epilepsy and everything to do with seizures. So they're absolute wizards, for example, at reading EEGs, which are like what I like to call to patients the sticky dot test, when they put all those sticky dots and glue all those leads onto someone's head, and then either have them walk around with a beanie on in the community, getting recordings of what's happening to their brainwaves, or they might be in a hospital bed, being videoed as well, so that we can see if they have a seizure, what that looks like in terms of what's happening to their body, but also what's happening to their brainwaves. And so once they've had this really good workup, the EEG techs, the neurologists, myself as a neurosurgeon, neuropsychologists sit down, and together we try to put together a picture. And we often bring a radiologist along as well, because in addition to having just like a normal MRI, there might be some advanced sequences that we get. And there's often some additional tests that patients would have if they're having one of these comprehensive epilepsy workups. SPECT scans, PET scans, and they all need interpretation and correlation. So it's a long, detailed conversation to come out to the other end of that with a conclusion, which will be, look, there isn't a specific area that this seizure is coming from that we think we could do a specific operation for, or actually, yes, there's something we could do. So broadly, there's kind of two groups of operations we do for people with seizures. One is where we're actually trying to get rid of the seizure focus and hopefully get someone to a point where they don't have they don't get those seizures anymore. And so the most common one of those that I do is taking out a significant portion of the temporal lobe, so a temporal lobectomy. The temporal lobe is often the naughty part of the brain in seizures. So there's a specific pattern to the kind of seizures that people get if it's the temporal lobe that's kicking off. And so we would go into that operation having a strong sense that this is what's driving this patient's epilepsy, and then go through quite a detailed consent process about what function could be affected, and what is the likelihood of cure for their epilepsy, and all these sorts of things. And then we take out a significant portion of the temporal lobe. And people are a little bit sore after this because I have to cut through the temporalis muscle, which actually helps you chew. It's one of the accessory chewing muscles. I try and put loads of local in there and give them, just the right meds afterwards, but that can often be a bit sore. Afterwards, we give them all that information. And if they think, yep, it's worth it, let's give it a go, then that's what we do. So less commonly, we find there's another part of the brain where it's very active and there might be something that looks obviously unusual on the scan. Sometimes there's nothing quite as unusual on the scan as you'd want to see it. Often a really good look at a scan shows us something that we think, oh, actually, that might be a low-grade tumor that's causing this. And so then we might take that out with the goal of not just taking out the tumor, but also dealing with the epilepsy. So there's that kind of operation. We're actually trying to fix the problem completely. And then there's a group of operations that we do where we're trying to modify the disease. So those procedures have been described as palliative in the past because it's like you're modifying the disease, but you're not getting rid of it. So they're still going to have epilepsy, but they might have less dramatic seizures. So I do two operations that I would say fall in that category. One is called a corpus callosotomy, where basically we disconnect the corpus callosum, which is the connection between the right and the left hemispheres. So almost completely. So I normally do 4/5 of that from front to back gets disconnected, using a microscope. And then the other operation I do that's in this kind of category is putting in something called a vagal nerve stimulator. So it's not even brain surgery, Benj. You're operating on the neck and in front of the pecs.
Yeah.
So you put a little lead around the vagus nerve as it goes down the neck or up the neck. And then you take a little battery pack, a little generator. So it's got a little computer in it and a battery. And you put that in where a pacemaker would go. Mm-hmm. And then you connect the two with a lead, and it's all under the skin. And so for some patients, that helps to modify their seizures and brings them to a place where their seizures are either less frequent or less intense. Very occasionally it gets rid of them altogether, but we certainly don't, advertise that that's the likely outcome. That's an unlikely outcome.
Yeah.
So there's a whole range of good stuff we get to do. And I'm really passionate about this, as you might be able to tell.
I can tell.
These are wonderful operations to get to do, and they can be completely life-changing. Epilepsy is a devastating disease, and it limits people's lives. It limits their present and their future. It has profound impacts on their relationships, on what they can be employed to do. And when you're a child with severe epilepsy, often you'll be on a whole bunch of medications trying to modify that. And at some point, you can be on so many meds and having so many seizures that it's affecting your development. So you're not meeting developmental milestones. You're not growing the way that you should be in terms of cognition and in other tasks. And so kids often won't be making progress in school, or they might not even be getting to school. So being able to interrupt that process as early as possible is really rewarding. And, the best case scenario is we get to give someone their life back. So I feel passionately about this, and I think that probably not enough patients get referred to complex epilepsy centers and to comprehensive epilepsy centers. So if there are any, people with epilepsy listening to this, or general practitioners with patients with epilepsy, make sure they've seen a neurologist recently at one of the centers where we do epilepsy surgery, because often it's really late in life that it gets picked up that something could have been done.
Yeah.
And unless you're so, there's an age group where we'd say, probably not appropriate for elective cranial surgery, but people in the 50s, 60s, 70s, we would consider doing something if we think it's going to make your life better.
Yeah. You've answered a lot of my additional questions in that. I think that was...
I got carried away.
Well, you really showed your enthusiasm for this, because it's obviously something that does impact so many people's lives in so many different ways. You mentioned the relationships and the work aspect, but also that development side. You did mention a couple of points where you're talking about, removing parts of the brain, but you also highlighted that it doesn't always have to be that. So I guess, what are some of the other options for patients with epilepsy who, let's say they're not a candidate for brain surgery and they can't get that device that you were talking about, which sounds really, really awesome. What are some of the other options for patients with epilepsy?
So I think if someone's, the real key is to have a good epilepsy neurologist who's, a big part of your team, because there are always new medications becoming available. And there are also, things that would have seemed like kind of crazy a couple decades ago that are now, we're getting more and more evidence about how they help, like cannabis products, for example, getting that prescribed properly by an epilepsy doctor who knows what they're doing. There's also some patients who benefit from being on a keto diet. So there's a real range of things that can be helpful and can be part of the solution for patients with epilepsy. And having a proper epileptologist driving that program for you is really important for epilepsy patients. They really deserve that.
Okay, it's good to hear.
And I mean, the way I'm talking about them, you can tell that I really appreciate my neurologists. Yeah. I appreciate them enormously. Most of the operations and the care that I enjoy providing the most is the stuff we do as a team. And epilepsy surgery is a particularly good example of a team sport.
Yeah. On that surgery of epilepsy patients, sometimes it is removing part of the brain. So what does recovery from a surgery like that look like?
So for most people, it'll be, needing to get through that post-operative period of feeling a bit sore and sorry for yourself. Sometimes people have a few seizures after the operation just because we've been in there and we've stirred things up. And so if people are having bad seizures around the time of the operation, that might slow them down. They might end up being in hospital a little longer because of that. I normally tell people they'll be in hospital on average somewhere between like 3 and 7 days after an operation like that, but with the caveat that some of these procedures, people do seem to take a little longer. Also want people to know that sometimes you need some rehab after you've had epilepsy surgery. And it may be because there's been some function that, isn't as it was when you came into hospital, and you just benefit from a little bit of finishing school before you actually get back into the community.
What might be an example of that change in function?
So if someone's got a bit of trouble finding words, for example, often we find that can be a thing that happens after someone's had a dominant hemisphere temporal lobectomy. They can find, just a little bit of extra challenge with that. So giving them a bit more time with speech pathologists and also occupational therapists to kind of come up with some strategies around that. That can be important.
I think it's crazy that, your dominant side, because like for me, when I associate dominant side, it's basically the main thing is how I write or play sports. But you're saying it also influences things like epilepsy. I just find that such an incredible concept that there is a difference because I'm a left-handed, that I have, would it be my left hemisphere or my right?
No, so actually left-handed people, so almost all right-handed people are left hemisphere dominant for language, but not all left-handed people are right hemisphere dominant for language. In fact, it's much closer to like half and half.
Wow.
So if you needed, God forbid, Benj, you should need neurosurgery.
Touching wood.
I would be keen to get a functional MRI for you where you basically go into the MRI scanner, but you get to do homework while you're in there. So you have tasks, like they might show you a picture of a dog. And then when you say, when they ask you what that is and you say that it's a dog, they see which side of your brain lights up. Where's there more activity? And that would tell us, for making words, this is the part of Benj's brain that does this. But we know that if we showed you a picture of a dog, you'd just be like light up with happiness, right? So that might be a bad example.
Yeah, that would be something that would happen for me personally.
Yeah.
We do love dogs here. You mentioned a few times that, post-surgically they might have a couple of seizures, and it sounds like brain surgery might not necessarily be a cure. But I think it's important to talk about, it is a whole life. It's someone's entire person. Can we talk about the benefits of having a procedure that really improves the quality of life, and, how that might be a fearful option because it doesn't solve the problem, but it really can change someone's world?
So the corpus callosotomy is a great example of an operation where we're not curing your epilepsy, but hopefully we'll change a particular aspect of it. So specifically with that operation, what we're trying to do is stop what would be basically like a regional storm in one part of your brain from being a problem in the whole brain. So once it crosses the midline and it affects the structures on both sides, then what we can have is seizure activity, in both arms, both legs. And the real problem with that is that if you lose tone in your legs, then you fall over. And so by the time I'm doing a corpus callosotomy on someone, they've often broken their nose a number of times because they've had so many drop attacks, they've had so many falls. Their family might describe times where they had near misses, where they, almost fell down the stairs. Those sorts of really life-threatening type accidents can happen. And people who have epilepsy have a higher risk of dying. This is partly why we take this so seriously, is because, if we can lighten the burden of the seizures, we can change the likelihood of them getting to live to old age. So with a corpus callosotomy, I don't think I'm going to get you seizure free, but I'd like you to stop landing on your face, falling downstairs, doing that sort of thing. So I've certainly had a couple of patients where it's really not just given the patient their life back, but it's given their family their life back because they don't have to be around 24/7. So if you can imagine being a teenage boy where your seizures are so severe that either your mum or your dad has to be with you all of the time, I mean, what kind of life is that? That's really challenging. You're going through all these changes and developmental stages, but there's a whole bunch of life activities you're not participating in because mum's always there. And I think that that's a strain on everyone.
I was going to say, yeah, you're talking about that patient experience, obviously, as a teenage boy. If my mum was, over my shoulder
holding your hand every
I
time
would
you're
have
out
lost
in
it.
public,
Yeah.
holding your hand every time you walk down the street. Like, can you imagine?
Yeah, but then from the parent's perspective, being able to let them go off because you know that they've had something that gives them a bit of their life back, and you get to give them this life that you'd probably grown up imagining that you'd be able to give to your kids. So it really takes that I guess weight off the people involved's shoulders and gives them a bit of their life back as well, because at the end of the day, parents and family members who are worried about their family members, they're always going to be there. But being able to give them some of their life back is also really important.
Huge. And it affects the whole family, and that's the thing is, one of the things I like about pediatric neurosurgery is that everyone remembers that people belong in their families. And so everyone remembers that what affects the child affects everybody. And sometimes we forget that in adult medicine. We forget that, no, this person lives in a context, and what happens to them does affect the people around them. And, it might be affecting their partner, their kids, the rest of their family. It might have an impact on their pets, it certainly has an impact on work. So remembering that this isn't just
as well.
And friends, absolutely. Like, people hate to see their friends suffer.
Of course.
And, there may be activities you just can't take a certain friend along for because they're not safe for someone with seizures. People who have bad epilepsy, they can't just go swimming because if they have a seizure out there, they're going to drown. There are people who can't have a bath because that could be something where, if they're having a bath and they have a seizure and no one's there, it could be fatal. So you think about all the ways in which freeing someone up improves not just their life, but their whole world. It's pretty fantastic.
Yeah. You're pretty much giving them their life that they always wanted, which is incredible. Thank you for doing that for them.
I wish we could do it more. I wish we could do it for more people, and I wish we could, and I think we're always looking for ways to do it better.
Yeah.
Yeah.
Of course.
Yeah.
We've got a couple more things that we want to talk about. We touched on the fact that, not all brain tumours are cancerous. But let's say someone were to hear the words, brain tumour. What are the key things that they should understand first to help them comprehend that?
So I think it's useful for patients to have a look at their scan, and then they can physically see what is it that we're looking at and where is it relative to other things like their nose and their eyes and their ears, like which side is it on, or is it right in the middle? How big is it? People like to know how big things are. So I'm like, what does it, fine. They want to know, okay, so now I just get out the calipers on the computer and measure it up for them if it hasn't already been measured, so they can see, oh, okay, that's the size of a grape, or that's the size of a, it's always fruit for some reason, or a golf ball, or, some kind of sporting thing.
Yeah.
And I think that helps people to try and get their head around it. And you're watching them cope in real time. They're watching them cope with what's going on in real time. So giving them as much meaningful information as possible. People want to know what the future holds, and I don't have a crystal ball, but I do have a set of expectations about what their journey is going to look like based on everyone else who's come through with a similar looking thing. So letting them know that.
Mm-hmm.
The other thing is sometimes people come to me and they've already been given a set of information by a well-meaning non-brain tumor expert. So sometimes we have to find out what they already think, and it may be something that they've figured out, like either the pediatrician or the GP or the emergency doctor has said something, and they might have said something correct, but they've misinterpreted it, or they might have said something that's maybe just a tiny bit misleading for them. So it's always really useful to make sure that what they've already laid down as the facts of the case are accurate and are relevant to them.
So it's almost like starting the conversation of, what do you know so far?
So what do you know? What's your understanding of this? What would you like? What questions are already on your mind? We'll cover everything, but also sometimes they do have that burning question right up front. So knowing kind of try to get them to set the agenda a little bit, this can be really helpful.
We've spoken about recovery a lot and that it's very different and it's an individual experience. What are some of the factors that can, influence how someone recovers?
I think that the patients I've had who've recovered really well, some of the things they seem to have in common are being children. Children recover, generally speaking, much better than adults. everything still works. They don't get sore knees when they get out of bed in the morning, all this sort of thing. But I think if you have a patient who has kept themselves in pretty good shape, is actually taking care of their body and like exercises regularly, then that patient's going to have an easier time after most operations than someone who hasn't prioritized that. And so it's been a lesson to me in my own personal life that looking after yourself is partly an investment in your life now, but it's partly an investment in your future, because it would be foolish to think that I'm never going to be a hospital patient. And one day I'll need an operation for something. And that will go better if I've made an effort to make sure that I have certain amounts of flexibility and cardiovascular fitness as well as strength going in there. So there are some procedures for which patients actually would go through like prehab. Normally when I'm seeing patients, it's for cranial conditions where there's not really necessarily heaps of time to wait and, like take months to get ready. But I think it would be lovely if everyone had an opportunity to kind of almost do a physio or an exercise physiology type program before they came into hospital, because for almost everyone that would make their hospital journey better. So at the same time as saying that, I know that, I never want to blame a patient for how they're doing postoperatively. What happens, happens. And as long as someone's committed to participating in whether it's physiotherapy or occupational therapy to help them get home, I think that the motivation can make a big difference as well. And one of the other factors is, I certainly really feel for people who don't have supportive friends or family around them. I think their journey of recovery is much harder. So one of the challenges all of us have, I suppose, is asking for help. Mm-hmm. But being able to ask for help if you are going into hospital and call on your friends or neighbors to provide you with a little bit of extra support can make a real difference.
Yeah. Lean on the people around you.
Yeah. This is the time.
Yeah. I like hearing that.
Why save the fine china? Now's the time. Yeah. Cash in all those favors, you know?
Absolutely.
Yeah.
This next one might be a bit uncomfortable to ask, but I think it is definitely important. Can things go wrong in brain surgery, and how do you talk about the risk with the patients?
So I think we talk about risks as part of the consent process for every operation. And we let people know that even though something's unlikely, it's possible. And we try to paint a picture of what that would look like if those complications occur. I think that having those conversations candidly equips you for when something does go wrong. And sooner or later, something will go wrong. And so if someone wakes up from an operation and they have a new weakness, for example, that they didn't have before, being able to be very honest is the key. And so open disclosure is absolutely imperative. Letting them know, this is what's happened, and this is where we are now, and this is what I expect the future will look like. And making yourself available for any questions that they might have is really key. And it's super uncomfortable if you know that someone has had a complication from an operation that you have done. Even though we know that that's part of the journey of surgery, and as hard as we try, we can't get the complication rates for, big operations down to zero. We still always want that for our patients. We wish for that. And I care deeply about my patients, so I find myself feeling, very upset if this is something that happens. But being really honest and open and making yourself available for the patient and their family and checking in on them frequently while they're recovering is really important to this. And I think the kind of thing that goes through my mind and the thing that I say out loud at times like this is, we're in this together. You're not alone. And then you have to prove that and show that with your actions.
Yeah, sounds like it's very much a nice thing to hear, that it's not something where you relinquish your responsibilities. You're very much a part of this experience with the family, with the patient, with everyone involved. And from what it sounds like, a key thing for patients to take away is that the people that are a part of the medical team are very much there to do everything that they can. And you're asking them to use you as much as they can, because you will provide all the support that's needed. Well, and if it's not you, it's who to give them that support.
That's right. And we know what the team looks like, and we know that drawing on that team will improve their next steps.
Yeah.
in literally and figuratively.
Yeah.
Yeah.
Beautiful. We're going to move into some myth-busting quick-fire questions.
Amazing.
So there are some, questions and common misconceptions. This one is a favourite of mine because I've seen lots of shows. Do I have to be awake to have surgery on my brain?
No, I think that there are a small group of patients who benefit from having awake surgery. I've done a few awake craniotomies for patients that had something near an eloquent area of brain. So some people would benefit from that, but not everyone. And the vast majority of surgery that we're doing, you're fast asleep.
Count back to 10, never made it past 3.
Exactly. There you go.
Can brain surgery change my personality?
That's a great question. I think it's very unlikely. There are instances of times when it has made a real difference to how someone thinks or feels. Mm-hmm. My hope is that you're still you at the end of the operation, even if you feel a bit groggy. But it's certainly a possibility. There's a wonderful book I like called When the Air Hits Your Brain. And it was written by an American neurosurgeon called Frank Furtosik. And the name of the book refers to a phrase which is one of the rules of neurosurgery he's exposed to very early on in his career. And the first rule of neurosurgery is, you ain't never the same once the air hits your brain. So it is, big stakes operating on people's brains, and things can change.
Okay. I think that's a good way to put it. How dangerous really is brain surgery?
It's as safe as we can possibly make it, but it is a high stakes game. And so many of the things we do around the time of surgery are made to improve the safety profile of surgery. And we have benefited in surgery from using insights from other industries, like the aviation industry, to improve safety profiles in theater. And so one of the things I'm most enthusiastic and evangelical about is a surgical timeout. So before we do your brain surgery, we're all going to stop doing what we're doing. We're all going to be quiet and pay attention, and we're going to go through a checklist. It starts with introducing every member of the team who's in the operating theater, checking who the patient is, checking if they have allergies, and then making sure we're doing the correct operation on the correct part of the body. Making sure we've got the right imaging available, that there are no pressure area concerns, that they've had antibiotics, that they've had all the other medications that we might want them to have, and that everything has been optimized for a safe operation. And anyone can speak up at any point in that and go, actually, guys, I think we've just lost this drip. Okay, we're going to let you do that. We'll let you sort that out before we get started. Making sure that we haven't, they are allergic to that. I'll have to use a different prep. Like that kind of stuff. Just making sure there's no area where we haven't gamed ourselves for success in every way, and that we have a shared mental model. So it's a bit like a cockpit, right?
That's what I was imagining.
We want to get it right. So yes, there are risks, but the entire enterprise is geared at reducing them.
Yeah, and I think for anyone who's looking for a zero risk surgery in any part of surgery, might be looking for a very long time.
Correct.
Another quick one: will I lose my memory after brain surgery?
I hope not, but it is certainly possible. Particularly some of the epilepsy surgery that we do, if we're operating in the temporal lobe and in the mesial temporal structures, we can things like the hippocampus, we can affect memory, and so often we do a pretty extensive workup ahead of time with a neuropsychologist to try and figure out exactly what this person's working memory is like to start with, so that we can appreciate what deficit they might have at the end if we go forward with what we're planning.
Yeah, nice. Does having brain surgery mean I won't be able to live independently afterwards?
I sure hope not. If someone's living independently when they go in for brain surgery, I would very much hope that it wouldn't change that. There are times when things happen and that is not the outcome. And the other thing to say is that sometimes you're dealing with a patient who's, when you meet them, already deteriorating. So someone who's come into hospital with a big malignant brain tumor, for example, they might have been living independently on Tuesday, and Wednesday they're in the emergency department finding out something bad has happened. On Thursday or Friday, they're having a big operation. And then by next week, it becomes apparent that they're not going back home on their own because everything has changed. And it's not just the brain surgery that's different. It's the brain tumor and the effect it's already had on their brain. And it's sort of like everything catching up to what's happened to them.
Yeah, completely understand. Can seizures get worse before they get better after epilepsy surgery?
Oh, absolutely. And in fact, it's an important thing that people should know. It's certainly not predictive what happens in like the 48 hours after an operation. You know, we've just been in there, we've been stirring things up. It's what happens in the medium to long term that's most predictive.
Yeah.
Yeah.
Okay. Is brain surgery more risky in children?
I think that unless it's very small children, it's probably less risky than in some of our older adults. There are different risk profiles. The one thing that very small children and babies are vulnerable to is any blood loss because they're so little baby. They have, you know, like sometimes they've got like basically a cup of tea amount of blood in them. So you can imagine like every drop you lose, you've really got to aim for trying to do as bloodless an operation as you can. And for those patients, we sometimes have cross-matched blood already ready in the operating theatre or right next to the operating theatre so we could start transfusing early. So the risks are different. The bleeding risk is probably the biggest one where not very many mils of blood need to be lost before we have a problem with blood pressure and heart rate in little children. But in most ways, I find kids recover better than adults. And they seem to be less prone to get postoperative infections of various kinds. And certainly their hearts and lungs in most cases are much more suited to the task of going through a general anesthetic than some of our older adults, or certainly adults with other health conditions.
Cool.
Yeah.
Nice. This is a big one. Will brain surgery affect my child's development and learning?
So we normally would only do brain surgery if we thought that it was either going to help that or have no effect on that. Particularly with epilepsy surgery, if we're able to reduce the amount of seizures that a kid is having, or best case scenario, stop them, then over time they might be able to come off of all those really strong anti-seizure medicines that they've been on. And often it's a combination of the seizures and the anti-seizure medicines that have been kind of holding a kid back. So once their sort of medical burden lightens, they can actually often be seen to have like big strides, big improvements developmentally. And that's exciting. Now, some kids don't ever like quite catch up to their peers, but they actually start to, lay down new memories, put on weight, improve with their language, start moving around more, any number of things. Yeah, they start to actually, tick some milestones off.
And I think it's also important that it's their kids' milestones. It's individual milestones. Milestones don't have to be the same for everyone.
Yeah, and everybody's different anyway. Most people don't benefit from terribly tight scrutiny. There's always something to find. And when you have a kid who's kind of been medicalized and has a condition, then everyone's just like watching like a hawk. And so no matter where your kid is up to with development or disability or seizures or tumors or anything, I think one of the things I really like to emphasize is make sure you take time to enjoy your kid. You have a wonderful, beautiful child. Make sure you get time to enjoy them and really just do the fun things that you can do with them. Make sure that it's not always about the medicine and the badness. Yeah.
I like that. I like hearing that. So we are getting closer to the end. So a couple of final thoughts. This is obviously called the patient in the room. So when I'm sitting in the room as a patient, what do you wish I felt more comfortable asking?
I really hope my patients feel comfortable asking me what their deepest fears are, what they're really worried about. And actually, you've touched on a lot of things I think people worry about. Things like memory loss, personality change, postoperative pain. People often are really worried. They want to know, am I going to die? And I hope that my patients, that I make enough space for them to ask those questions, that they can ask the thing that's worrying them the most so that we can really get to the bottom of that.
Yeah. I think having the scariest thoughts given the space that they deserve, because you are walking into a position where, as a patient, you're handing over everything, and it is a common thought. I don't think this is just for neurosurgery, but it's a big question to ask: am I going to die?
Yeah.
And it's a safe question. It's a safe space to ask that question, and it's a very valid question. I think that goes back to you saying all your thoughts and fears and feelings are valid.
Everything's valid.
Everything.
There's got to be room for it.
100%.
Yeah.
And if someone's listening, one day might need neurosurgery as an adult or for their child, what's the most important thing you want them to know going into that experience?
So I think I want all of my patients and possible future patients to know, like, we're human beings too. And we have, ups and downs as well. And none of us are perfect. But what we really want to do is be in partnership with you, with your kid, with your family, as you go through what could potentially be one of the, most difficult parts of your journey, but which hopefully will be something where you always feel that your humanity is upheld and respected and that your wishes are really at the forefront.
Amazing. That's really beautiful to hear. Thank you so much for joining us.
Thank you for having me.
You've provided a lot of clarity around a lot of things people question and might not feel they can ask or don't know who to ask if they're living with, whether it be epilepsy or a family member or friend who's got a family member or friend with any of these conditions that we've spoken about. So really thank you for sharing your knowledge and highlighting the impact that you and lots of others are having on lots of different families. This has been Patient in the Room. Thank you all for listening.